Complexity of odontogenic infection. Infection of spaces in relation to the lower jaw. We begin with the perimandibular spaces, which involve submental, sublingual, and submandibular space. Submental space infection. The source of infection is one direct source from infected lower incisors and canine, lower lip, and skin overlining the chin, or from the tip of the tongue and the anterior part of the floor of the mouth. 2. An indirect source of infection from submandibular spaces. The clinical picture is painful submental edema and generalized constitutional symptoms. Blunt dissection, rubber drain, and antibiotic administration. The site of incision and drainage is 1. Extraorally. Horizontal incision through the skin, posterior to the crease, behind the chin, providing most aesthetically acceptable scar, and 2. Intraorally through the mentalis muscle via the labial vestibule. Sublingual space infection. The source of infection is 1. Directly, it's usually from premolar and less commonly from molar teeth, and 2. Indirectly, the infection may spread from submental and submandibular spaces. A clinical picture is raised tongue, sublingual swelling, dysphagia, enlarged painful submental and submandibular lymph node. The treatment is by incision, drainage, rubber drain, antibiotic administration. Site of incision and drainage is intraorally by incision through the mucosa only, parallel to the Wharton duct and lingual cortex, in anterior-posterior direction and away from the sublingual fold. Number 2. Extraorally through submandibular and submental incision through the mylohyoid muscle. Directly from lower molar teeth, especially second and third molar. Infection can also spread from the tongue, posterior part of the floor of the mouth, upper posterior teeth, cheek, palate, the maxillary sinus, and the submandibular salivary glands. And 2. Indirectly, the infection may spread from infected sublingual and submandibular spaces. The clinical picture is painful swelling, obliterating the angle of the jaw, tenderness, generalized constitutional symptoms. The treatment is by incision, a blunt dissection, rubber drain, antibiotic administration, fluid replacement, and bed rest. Site of incision and drainage is extraoral incision, made parallel and about 2 cm below the inferior border of the mandible. The incision extends through the skin and subcutaneous tissue only while the space is entered. Serious condition, the etiology by dental infection, submandibular celladinitis, injury to oral mucosa, or fracture of the mandible. The clinical picture is by marked difficulties in swelling, odynophagia, trismus, infection located in sublingual spaces, infection spread to submaxillary spaces, and laryngeal edema may. The treatment is by systemic antibiotic, incision and drainage of the abscess, intraoral if infection localized to sublingual spaces, and extraoral if the infection involves submaxillary spaces, and a tracheostomy if airway is engaged. Buccal space infection. Source of infection can relate to both jaw. The infection spread to buccal space, otherwise the infection spreads intraorally into the vestibule, where it can be drained easily. Clinical picture by intraoral bulging, extraoral swelling confined to neck, throbbing pain, and generalized constitutional hydration and bed rest. Site of incision and drainage intraorally by horizontal incision in the buccal mucosa below the parotid duct. The incision should be through the mucosa only. The incision can place extraorally if the pus point Submastocytic space infection. The source of infection usually from molar teeth, especially lower third molar. It can also occur after a fracture of the angle of the mandible, or it can spread from buccal spaces. Clinical picture by deep-seated severe throbbing pain, swelling over the angle of the ramus, and marked trismus. Treatment by incision and drainage, antibiotic administration, rehydration, and bed rest. Site of incision and drainage is extraorally, below and behind the angle of the mandible. The incision is carried through the skin and subcutaneous tissue, then by blunt dissection through the platysma muscle and deep fascia. Intraorally drainage can be carried out through an incision along the anterior border of the ramus of the mandible. Molar teeth, especially lower third molar, gunshot wound, complicated fracture, orthodontic surgery. Or it can also result after inferior dental nerve block with contaminated needle or solution. Infection can spread from submandibular, sublingual, and infratemporal spaces. Clinical picture by severe trismus, intraoral swelling, dysphagia, air hunger, and general constitutional symptoms. A treatment by incision and drainage, intraorally if only pterygomandibular space along the mesial temporal crest, extraoral if multiple spaces, rubber drain insertion, rehydration, antibiotic administration, and bed rest. Site of incision and drainage is extraorally, the same as submastocytic space infection, but directed to the inner surface of the ramus, or intraorally can be drained through an incision made just medial to the pterygomandibular raphe and dissecting along the inner surface of the ramus. From upper and lower molar teeth, most commonly from lower third molar, infection by a way of submandibular, sublingual, and pterygomandibular spaces. A non-odontogenic infection can spread to this space like tonsillar infection. Sign of symptoms: the patient exhibits pain, fever, chills, medial bulk of the lateral pharyngeal wall, extraoral swelling below the angle of the mandible and trismus. It may lead to respiratory obstruction, septic thrombosis of internal jugular vein, and carotid artery hemorrhage. Treatment: incision and drainage, intraorally or extraorally, rubber drain insertion, antibiotic administration, rehydration, and bed rest. Site of incision and drainage, intraoral incision medial to the pterygomandibular raphe with the dissection medial to the medial pterygoid muscle, or extraoral incision at the level of the hyoid bone anterior to the sternocleidomastoid muscle. This is located in the tissue in the back of the throat, behind and posterior to the pharyngeal wall. It extends from base of the skull to vertebral level between T1 and T6. It may lead to airway obstruction or sepsis, which is both life-threatening. Etiology: bacterial infection originated from nasopharynx, tonsils, sinus, adenoid, or sore middle ear, and may result from direct infection due to injury or foreign body. Odontogenic cause: clinical picture: stiff neck, some form of palpable neck pain, malaise, difficult swallowing, fever, drooling, croupy cough, and enlarged. Management by tonsillectomy, antibiotic administration, rehydration, and bed rest. Peritonsillar abscess or quinsy is a bacterial infection that usually begins as a complication of untreated staph throat or tonsillitis. Source of infection: it arises from tonsillitis, but occasionally complication of pericoronitis of the lower third molar. It causes swelling to the anterior pillar of the focus and bulk of soft palate or affected side. There is acute pain, dysphagia, the voice becomes muffled, odynophagia, drooling, and anorexia. Site of incision and drainage is a place in the point of maximum fluctuation and can done under local anesthesia, and if general anesthesia we should prevent aspiration and the patient should be head down.